So welcome everybody. This is our COVID-19 Outpatient Noon Conference, June 4th, and continuing in the theme of recent conferences, it's to address pertinent clinical questions for outpatient care of COVID-19. Our speaker list today includes volunteers for cases, Colin Johnson, who is from the Emory Bariatric Center, but currently working in the virtual outpatient management clinic, taking care of patients with COVID-19. Myself, and I'll be presenting some data from virtual outpatient management clinic. Clyde Parton, who is professor of internal medicine and director of what we call the diagnostic clinic, and Kevia Sebastian, an assistant professor with digestive diseases and someone that we work with clinically often, and a pleasure to invite her to share knowledge with us from the GI perspective. So with that, I'm going to switch PowerPoints and we'll go to Colin.
All right, thank you very much, Dr. O'Keefe, and thank you everyone else. So my presentation is nothing earth-shattering. It's more to kind of highlight the duration of symptoms that these patients have, and often the overlooked GI side of this. So first, this is a pretty healthy 31-year-old female, obesity, allergic rhinitis, nothing really major going on. Her COVID disease actually started with diarrhea, fever, cough, myalgia, shortness of breath. And it was pretty significant diarrhea, you know, it was 4 to 7 times a day. It started initially in the first week, it got better without treatment. And then kind of approaching the second week, in the middle of the second week, these things just came right back without any kind of indication as to why. So again, 4 to 7 loose stools a day. And with this, she has this morning nausea, which is very common in the patients that I've seen for COVID. Typically they wake up just nauseated and they don't eat until later in the day. And it's only a very small amount and the cycle kind of repeats. So this actually continues from day 11 for 2 weeks. So she has these stools daily. It's not frank diarrhea. Sometimes it's a little less formed. Sometimes it's a little loose. And the only thing that really seems to kind of help the diarrhea is loperamide, which brings a staggering, 8 stools a day down to, I guess, a more pleasant 5. So that's an improvement. That's a little less time on the toilet. And even a month and more out from the start of the disease, she still has this mild nausea, especially in the morning, even though most of her respiratory symptoms have all resolved. In her case, she doesn't want to use Zofran, and the Pepto she tried is pretty ineffective. So the only thing that really seemed to work for her was the Imodium, and she would eat as she could, but every time she ate, it was in small amounts because it would increase the kind of abdominal cramping and make the nausea worse. She tried to push past that point. All right, so the second one's a little older female. Her really only comorbidity is she's had a history of chronic bronchitis, where she's had pneumonia for a few times throughout her life. Was not on any kind of current bronchodilators, but she started some when she joined the clinic. And her actual initial symptoms were diarrhea, nausea, and vomiting that then led to some shortness of breath about a day afterwards. And for the first 2 weeks of the illness, she had this chronic nausea and usually vomiting 1 to 2 times a day. And Zofran was started about symptom day 16. So we don't see these patients at day 1. We typically see them symptom day 7 or more. So we can't start these medications very early on them, in our clinic at least. But she finally did have a first real meal 16 days into this after starting Zofran, and she was just very excited about it. And then with the starting food and better diet, the diarrhea actually improved, even though she still had some lingering nausea. Now, as COVID is a roller coaster of a disease, you see this progressive improvement, and then all of a sudden, there seems to be a day or two when things just kind of reverse. And that happened for her around day 26. And she actually had recurrence of the vomiting and the headaches that are very typical with COVID. And that sort of continued throughout the next 10 days. And she's actually still in our clinic. And The emesis has mostly improved, but she still has this morning nausea. And although the Zofran was highly effective about 2 weeks ago, it really isn't working very well right now. And unfortunately, it seems with a decent amount of our COVID patients, Zofran sometimes results in an increased headache. So we kind of treat one of their symptoms and exacerbate another one with this. And again, respiratory symptoms have mostly improved, but it's the GI lingering symptoms to this illness that will probably plague her for, I don't know, another few weeks. We'll have to see. And there's no real good treatment to this except for trying to get people to rest up, stay hydrated, and progressively push their diet, starting with kind of a brat diet. Again, this is nothing earth-shattering, just more to highlight the struggles of the complexity of COVID and its respiratory and pulmonary and GI. So what does this mean for the general population? If we go to the next slide, Dr. O'Keefe, the current research. So this kind of compiles some of the research out of China as well as some of the research out of California. Just kind of an overview of what we've seen as far as GI side effects, right? We've seen plenty of pulmonology and cardiology problems with this, but everybody knows everything comes down to poop, so the GI system has to be involved with this too. So the first one actually Dr. O'Keefe sent me was there's a change in the gut microbiota in a lot of these hospitalized patients that were in China, where a lot of the opportunistic pathogens increase, the beneficial commensals drop off. And when they find, of course, more of the opportunistic pathogens, there's increased severity of the COVID illness. The next one was pretty large, is 1,100 patients, and 16% of them had GI symptoms only. So you can kind of surmise that we're probably missing a lot of COVID cases that are just GI symptoms because we aren't really testing unless they have respiratory symptoms. So who knows what the actual percentage-wise of people who have COVID with GI symptoms only. But even in this case, there's 16%. So I mean, that's a pretty good number. That's 100 plus patients that you would see, since our clinic itself has seen almost 1,000 patients. The next one kind of touches on just GI symptoms in general. So a third of the patients have GI symptoms, which is a pretty significant amount. And one of the major correlating factors as far as severity of disease was elevated AST. And that'll kind of segue nicely into our next one, which was the AGA's rapid review of all these patients and the kind of GI symptoms. So the one thing they did say is that since there is proof of COVID being GI related only, that you could possibly test for COVID if they have a history of some sort of COVID exposure. Definitely don't make that your first. It's still a bit of a zebra, I guess, when it comes to GI symptoms only. If the patient does happen to get hospitalized, do a baseline LFTs, didn't seem to be very viable in the outpatient setting. There's no current recommendations for how to treat these. Like I said, we've done over-the-counter medications, prescription medications. I mean, is the next thing going to be probiotics? I don't know. We'll kind of have to see what pans out from this. But the GI symptoms are real. They're nagging, and they seem to prolong the kind of recovery phase of this due to the inability to eat and stay hydrated. So it's a pretty aggravating part of treating this disease.
I would like to touch on a couple of topics that we've learned from the virtual outpatient management clinic. First, review the duration of gastrointestinal symptoms in outpatients with COVID. Second, review the GI symptom frequency in inpatient discharges. And third, review provider perspectives on GI symptom management. So the first slide is just meant to illustrate the duration of GI symptoms. You'll note that in our cohort of patients in the virtual outpatient management clinic, we see these symptoms in approximately 1 in 4 patients. There are 3 symptoms here on this chart. Abdominal pain is the smallest curve. Nausea is the purple bar, and diarrhea is the light blue bar. You'll see that many of the patients have improved by the end of the 3rd week of illness, but a substantial portion have lingering symptoms into the 4th and 5th week. The second point is about hospital discharge patients. We have limited knowledge about the ongoing symptoms at discharge, and it is just based on chart review data, which does not capture all of the symptoms that our patients are experiencing. So in this case, we see that out of 320 hospital discharge patients, 7.2% are noted to have ongoing diarrhea at the time of discharge. a relatively small proportion of the prescriptions noted at discharge are antidiarrheal, with only 5 that we noted, all loperamide. The provider perspective, we received survey results about outpatient treatment from 23 RNs, 19 physicians, 24 advanced practice providers, and 2 LPNs. These were individuals who had cared for a large number of patients with COVID-19. In terms of how difficult it was to manage the GI symptoms, here you see a graph for nausea. The majority of respondents said it was not challenging. The advanced practice providers are seeing the tier 3 or high-risk patients over time, so that may be why they have seen some of the very challenging cases. Here is diarrhea, which you'll see is very similarly represented. And so both of these are regarded by providers as easier symptoms to manage than the respiratory or chest symptoms and anxiety.
So I have a 38-year-old male Spanish-speaking laborer with high blood pressure, overweight, did not smoke, did not drink. There's a big echo in there. Is the sound too bad for you guys?
It sounds great for us.
Okay. His symptoms started May 1st, so it's easy to kind of follow the dates here. If you start with 1 May, typical pulmonary symptoms, fever, and mild diarrhea. He then came to the emergency room late on the day of the 2nd with temperature of 37.3. His O2 sat was 98%. He did not appear ill. The ER doctor thought his lungs sounded clear. White count was 11,000. Did have hazy infiltrates. He was discharged with azithromycin and albuterol. You can forward the next slide. The test came back positive, and he came to my attention in the virtual outpatient medical clinic on the 5th. He said he felt better as of the day before, May 4th, but still coughing up yellow phlegm. He mentioned it multiple times during the interview that he just wanted to feel better. He mentioned some abdominal pain, which was not further addressed. This has started May 1st, but in the ER visit, actually denied abdominal pain. Diarrhea seems to have resolved. I placed him in tier 3 due to multiple risk factors, high blood pressure, pneumonia. I never did get a weight. He was just a BMI greater than 30. Went through a few days of follow-up phone calls. Headache was mentioned. There was inconsistent data regarding his diarrhea and abdominal pain. And I wondered if some of this was being perpetuated by the azithromycin. But in general, he was doing better. And on the 11th of May, there was a definite statement in the chart about no abdominal pain. His pulmonary symptoms were much improved, and his anosmia was better. Next slide. And then on the 13th, again in the evening, he arrived in the ER with complaints of chest and abdominal pain. Still had some diarrhea. ER doctor noted the right upper quadrant and epigastric guarding, and he seemed to be uncomfortable. Chest pain workup included the usual labs, troponins, EKG, and he had a PE protocol chest CT that did not show an emboli. They did note that his gallbladder was mildly distended and he had some gallstones and the colon wall was thickened. If you look at the labs here, the platelets had sort of a reactive thrombocytosis. White count bumped up a little bit here. Alk phos doubled, but still just a minimal elevation, slight transaminitis, so uncertain significance there. Next slide. The surgeons were consulted, and they got an ultrasound which showed some sludge. There was a disagreement among radiology and the surgeons about a gallstone that was in the gallbladder neck. The surgeons were less impressed by that finding. But they did state there was no active cholecystitis and there was a negative Murphy sign on sonography. They did start IV antibiotics. There was a discussion about C. difficile, but nobody got around to ordering. I don't think they were very convinced that was the problem. Interventional radiology was consulted to put in a tube to the gallbladder, but they decided they wanted to see a HIDA scan first, which had no visualization at 60 minutes. Therefore, they went ahead and placed the cholecystostomy tube. And he was discharged on May 18th, so we're now 18 days into this saga. On days 19 through 23, daily phone calls, he was continuing to improve, but was very sad. Next slide. So a little talk about COVID-19 and GI complications. We've already heard Colin talk about, looks like the same study, 16% had GI symptoms preceding pulmonary symptoms. In one hospitalized patient study, 61% had at least one GI complaint, anorexia and diarrhea being the most common. Another study, 204 patients, only 1.4% had abdominal pain. The Wuhan study, 84 patients with pneumonia, 31% had diarrhea, and then 69% of those had viral recovery of a virus from the stool, where those without diarrhea, only 17% had COVID-19 recovered from the stool. Not a lot of data out there on gallbladder disease and COVID-19. I found this one interesting article in the radiology literature in which they were sort of having an argument among themselves about describing the findings of the gallbladder in COVID-19, but overall, I didn't find it very useful for my purposes. One postmortem exam with 10 patients, they did not mention the gallbladder. They mostly talked about pulmonary symptoms, but they did biopsy the liver in all 10 cases, and they just noted minimal periportal lymphoplasma cellular infiltration. Tried to figure out if the gallbladder had these ACE2 receptors, and the answer is yes, and found the interesting comment that in the gallbladder, if you don't have the ACE2 gene expression, you're at increased risk for gallbladder cancer. Next slide. So this patient may have been at some risk for cholelithiasis due to obesity. He'd had a few mild elevations in glucose, but no diagnosis of diabetes. Gallstones are more prevalent in Western Caucasian and Hispanic population. So the bottom line is Kate Dromwood's conclusion, the interactive etiologic role of COVID-19 infection promoting cholelithiasis or cholecystitis, if you have cholelithiasis, is uncertain. I think we'll eventually tease out a little bit here, but I just don't think there's enough data to draw any conclusion. Thanks, Jim.
Thank you, Clyde. I will stop screen share, and Kevia, if you're ready, you can go ahead and share yours.
Sure, let me just make sure I do my screen share correctly. All right, are you?
Yep, we see it. Okay. That's great.
All right, well, thank you, everybody. I really appreciate the opportunity to come talk to you, and certainly I'll be piggybacking a little bit off of what you heard. I hope it's not overwhelming. There are a lot of studies I put here, so I mostly tried to put all the references so that you have time to peruse it at your own. Okay, I have no financial disclosures. So as people have mentioned early on, the thought was that this was mainly a respiratory illness. Some of the initial studies, particularly the ones that came out of China, you know, if you look, the big thing was that diarrhea was uncommon. Going forward, by March, I think we started recognizing that that wasn't quite true. So this was one of the first big studies that came out around March of this year from Hubei, China. And basically, they realized that a good chunk, so this 41% here, these are people with just respiratory symptoms, no digestive symptoms. But if you look at this 47% over here, these are people who have overlapping GI and respiratory symptoms. And when you add in this other slice of the pie up here, another 3% who just had respiratory symptoms, you're now approaching half of the patients had at least some GI symptoms on the table. They basically started out by saying that they noticed that there was a significantly longer time from when the patients first had symptoms to admission than the patients who had no GI symptoms at all. And you'll see that that's a common theme. Other things they noticed were that they often had higher liver enzyme tests. Some of these other diagnostic labs haven't panned out in some of the other studies we'll talk about, but that they had a lower monocyte count, lower prothrombin time, and ended up needing more antimicrobial treatment than the people who did not have GI symptoms. This is a study out of Stanford University that was done in March. So they had 116 patients. They noticed that about a third of them had some kind of GI symptom prior to presentation. The vast majority of them described their symptoms as mild. This kind of ranged from loss of appetite, which was pretty key, a little less nausea, vomiting, and diarrhea presentations. And similarly to the study from Hubei, they did notice that there was an elevation of AST versus ALT, and that actually the elevation levels seemed to correlate to disease severity. They did not see any significant change in bilirubin or alk phos. This particular study did not note any patients who had solely GI symptoms or that was the first symptom. Additional findings, this was when they started to realize that the ACE2 cellular receptor appeared to allow uptake of COVID-19 into the GI tract, and it's widely expressed throughout the GI tract. They also started to realize there was liver involvement due to direct injury of the virus, and found on autopsy findings that there was steatosis and mild lobular as well as portal inflammatory activity. This is a study out of Boston from Brigham and Women's, 318 patients. I think Clyde might have actually mentioned this in his presentation. So this was interesting. This was a pretty high number, well over 50%. I mean, are presenting with some kind of GI symptom. About a third of them had anorexia, another third diarrhea, and then nausea maybe a little lower down. The patients presenting with GI symptoms, they also noted had greater fatigue and general malaise, also a sore throat. They also noticed that the people who came in with nausea and lack of appetite were reporting higher levels of loss of taste and smell. They, unlike some of the earlier studies, did not see any difference in demographics, labs, or disease severity, and that tends to be more consistent with the later studies. From Columbia, this was interesting because they actually did a case control. They took all the patients who were admitted and kind of split them down the center of were they COVID positive or COVID negative. So the people who were tested in the first place were people who had any kind of respiratory symptoms, so cough, shortness of breath, or had had some kind of fever. And this is in patients prompting admission or in any of the medical personnel working at Columbia. So amongst these people, in the people testing positive for COVID, they found that 35% of them, a good chunk of them, did have some kind of GI symptoms present. And when they extrapolated the data, they found that actually the presence of GI symptoms, which they defined as either nausea and vomiting or diarrhea, actually was associated with a 70% increased risk of testing positive in the first place. Patients with positive tests and presence of GI symptoms were more likely to have had an illness duration of over a week before seeking care, kind of like what Colin was talking about before. Patients who were positive, who had GI symptoms, seemed to actually have lower ICU admission rate and lower mortality and immediate follow-up, sort of suggesting that perhaps they had a more indolent form of illness. Also out of Stanford University, 207 patients, again, about a third of people, this number seems to keep popping back up, who presented with GI symptoms. They did find risk of hospitalization increase 5 times in GI patients, but they saw no overall difference in need for ICU care or mortality rates. So, overall, when one of the American GI groups did a meta-analysis of global studies, they excluded some of the early Chinese studies where they were not reporting any diarrhea because it seemed to skew so greatly because it was such a large study. So when they did a meta-analysis of global studies more recently, they found that about 18% of those coming in with positive COVID-19 reported diarrhea as at least one of their symptoms, if not necessarily the only or first symptom. So this is when we really first started shifting in probably late March, early April to start understanding that it wasn't limited to a respiratory illness. Now, obviously, these are retrospective reviews on people who are hospitalized. So was anything looking at the outpatient community, especially for frontline providers such as yourselves. So a group out of MassGen, in addition to a group of researchers out of the UK, came up with this tracker, an app that you can download for free, and used it for kind of having patients enter the symptoms and seeing what the profile was of the demographic who were positive. So this is kind of an interesting graph. So their take home, if you look at the title of their study, is actually that one of the things they were fascinated by is that loss of taste and smell seems to be a very strong predictor over and over again for the likelihood you may have COVID-19. In fact, I think we had a nurse who worked in one of our clinics who's young and healthy, and that was her only thing that was a little off, maybe some fatigue. They wouldn't let her test at the time. This was way back in March when they weren't testing unless you had a fever and a cough. And she got the antibody testing done more recently, and for what it's worth, it's positive. Not that we totally understand what the antibody testing means, but most likely, I would guess, she had COVID-19 and that was her sole presentation. So that's an interesting take home. But from a GI standpoint, if you look at the first 5 couple of symptoms here, after loss of taste and smell, you have fever, you have anorexia, fatigue, and diarrhea. So at least 2 of these are pretty solidly GI symptoms. And it's really lower down that you start to see in the outpatient community that cough and hoarse voice, shortness of breath, those things start to pop up, which is interesting. Another study on outpatients and mild disease severity came out of Wuhan and Union Hospital, and this was looking at outcomes and stool viral RNA testing. So they divided patients into digestive only, digestive plus respiratory symptoms, and respiratory only. You can see that actually digestive makes up a pretty good, almost third of patients here. So what they took home from that was 19% of people in the respiratory and GI symptom group actually reported diarrhea as one of their first symptoms. That's pretty significant, 20% of people. They said the average duration of the diarrhea was at least 15 days, but it seemed to last from anywhere from 1 day all the way up to 2 weeks, and they averaged about 4 bowel movements a day. One really good caveat is that 73% of the people who were COVID positive and had diarrhea also had a fever. So it kind of increases the predictive value if you have someone who's presenting with fever and diarrhea. On average, they were diagnosed later, probably because, as we've learned from many of the other studies, they seem to present later in the first place. And then the GI group seemed to take longer to achieve viral clearance as well. And then this study was looking at stool PCR, which is not but widely available, unfortunately. Like, we don't have it at Emory, to my knowledge, at any of our sites. And I don't think it's widely available, honestly, at most centers. But interestingly, in the center where they did do it, positive stool PCR was present in 53% of the COVID-19 positive patients. The stool stayed positive for up to 12 days, and it seems to delay beyond clearance of the respiratory samples for being positive. This is a nice little flow chart of diagnostics in looking at COVID-19. So here you have your area before the patient actually starts to feel sick. So here at week -2, maybe they have their exposure. And then about a week before they actually start to feel sick, you can see that if you went and swabbed them, if you had some magical way to know that they were positive, or say you got a patient who knew they had been around someone who was COVID positive and went and got tested, this is where the nasopharyngeal swab starts to rise, and it actually peaks in the middle towards the end of week 1 when they actually start having symptoms. This yellow line here is your stool PCR. So it's not quite as high as the nasopharyngeal, but you can see that it does start to peak a little later. So as the nasopharyngeal PCR is starting to come down, you actually have a little bit of stabilization of stool PCR. And then, as an interesting side note, this green line, this purple line is your IgM, and this green line is your IgG. So those come even later than both of those. So what does that mean? So patients, I think Colin already mentioned, patients with GI symptoms are more likely to have positive stool studies for COVID-19, probably just because of more viral shedding from the GI tract if they're actually infected enough to display symptoms in the first place. The other thing is they tend to present later. Now, some of it, like Colin mentioned, is I think for a very long time, just like everybody thought, oh, this is an old person's illness and young people don't get it. I think the initial strong emphasis of respiratory symptoms sort of led people to rule out other stuff. I mean, people have told me they went in with nausea, vomiting, or diarrhea and were actively told that they could not get a test because that was not how the disease presented. So I think they did present later for that. The other reason we speculate now is we're getting more knowledge and encouraging people that nausea, vomiting, diarrhea all might be symptoms is that people tend to have more indolent courses. So they feel, oh, it's some diarrhea. Maybe I ate something bad. I'm just a little under the weather. My toddler gave it to me. And they tend not to come in as much as the people who are having cough, trouble breathing. Those things make people more distressed and they're more likely to seek medical attention. So it's interesting, if you look at the previous slide, given the 70% accuracy of nasopharyngeal swabs and the fact that it kind of drops off starting in the second week, right when the stool PCR is starting to go up, if we had the option to, that might be an additional modality, particularly in people with GI symptoms, to obtain testing and maybe more likely confirm the diagnosis if the nasopharyngeal swab was negative. Obviously, this requires us being able to have access to more widespread testing. As far as method of infection, it's estimated that 90% of infected patients have it shedding into their saliva, and then we consume it during swallowing. They've done experiments where they've actually taken stem cells and grown them into small intestinal organoids and then deliberately exposed them to COVID-19. And what they found on viral RNA staining is that the virus gains access through the ACE2 receptors, and it very rapidly invades and proliferates within the enterocytes, literally within a day or two. As far as fecal oral transmission, does that mean that if this is possible, we're all handing it around to each other? We already know from, everything we've been told that contact doesn't seem to be as aggressive a form of transmission as respiratory and droplet precautions. But in some of these studies where they've swabbed the toilet bowl and sink samples, they found that you can shed virus in the stool and it can linger. They did find reassuringly that when you clean it adequately, it's gone when they resample the toilet bowl or the sink. And this is just another study where they looked at high surface areas. So they looked at public waiting areas, common areas, toilets, and areas where PPE were removed. And unsurprisingly, PPE areas were high areas of shedding on surfaces. But also they found that in toilet facilities, not just the patient's facilities, but toilet facilities, there was high shedding as well. Again, these are things that actually disappear with cleaning. So it highlights that not only in public places like hospitals, we should be cleaning, but at home, if you're sick and you have diarrhea, lots of aggressive hygiene to prevent it from transmission. There is some thought that, part of the reason it might be harder to get it from a GI standpoint in the first place is we know from previous SARS-CoV that it does not survive well in human body temperature and acidic environment, and that might be some of our barrier to it in the first place. So just a couple more slides here. Final thought, so about a third of patients across multiple studies seem to report some kind of GI symptoms, even if it's not their first symptom or their only symptom. Diarrhea with anorexia, and particularly if you throw in fever on top of that, high predictive value of COVID-19 being present, and you should definitely test them. Patients with only GI symptoms seem to come in a little later and take longer to clear the virus, but also seem to somewhat have a little more indolent course. Stool PCR may increase our diagnostic sensitivity, but unfortunately at this time, we don't have really good access to it. And then hygiene is really important for preventing possible fecal oral transmission. To kind of cap off this before I show you my last two slides, I will say that from the standpoint of supportive care, just like Colin was talking about, one of the hard things is it's largely supportive care. We don't have any studies coming out yet that say that any of these drugs or trials we've tried reverse GI symptoms in particular. So it is managing the diarrhea, managing the nausea and the vomiting. I wonder if, we aren't seeing a little bit of post-infectious gastroparesis or some post-infectious IBS, just like we do with traveler's diarrhea or food poisoning or things where people take a little while to reset after the acute illness is over because of the invasion of the GI tract, because that's a well-documented phenomenon amongst other illnesses. Couple last minute notes. For liver injury, this is a whole talk outside of the scope of today's lecture, and I'm not a hepatologist, but just to give you some of the updates from our societies, hepatic involvement of COVID-19 is common. Hepatocellular injury seems to be the most dominant presentation with abnormal AST greater than ALT. There are some reports of GGT, but these two are your really big ones, with the AST being much higher than the ALT. People with non-alcoholic fatty liver disease or cirrhosis or post-transplant seem to be at the greatest risk for sequelae from COVID-19, likely just because of how sick they are in the first place. On a day-to-day basis, there's no overall change in management. Some of the routine stuff like screening for HCC, varicose screening due to endoscopic procedures being necessary, and aerosolization should all be deferred briefly. And then right now our societies are talking about how to slowly re-implement endoscopy. No change in immunosuppression if they're stable. Obviously, if they actively are infected, you need to be on board with their hepatologist to discuss how to manage that. And finally, IBD patients, at baseline, similar to the liver patients, we should not be discontinuing their immunosuppressive drugs or their biologics just to prevent them getting it. There's actually nothing so far out of the 1,000 or so patients who have been studied to suggest that IBD alone makes you at higher risk. There's no extra expression of ACE2 in the gut. So we get lots of messages from the IBD patients concerned about it, understandably, but they should not stop their drugs. Obviously, they should take all the regular precautions, particularly if they are on immunosuppressives. But again, they should not just routinely be checked for COVID randomly at certain periods in time. It should only be if there are focal reasons to check them, like symptomatic presentation. No traveling, and non-urgent visits should be postponed if they can. Some people have to go in because of infusions. And this is kind of a little bit of a schematic coming out of the American Gastroenterological Association. So your mild patients, the ones who are not hospitalized or have pretty good saturations and no evidence of pneumonia, if they're on, so one big thing that I think has been a take home across all specialties is steroids do not do well in these patients. So just like with ARDS for IBD flares, if you can, you want to try to get them off of corticosteroids as quickly as possible and switch to budesonide, which has more of a GI pass. You can continue their anti-inflammatories, you continue enteral nutrition. You may want to hold their immunomodulators, and you should really have their gastroenterologist on board for this, but you may want to hold their immunomodulators and delay their biologics for 2 weeks before reinstituting. With the moderate and severe patients who are a lot sicker, most of this is actually the same. And then obviously focus on life support measures and any antiviral therapy where it has use. The idea is that when they're either testing as re-negative or when they're entering a phase of immunity, you could reinstitute their usual therapies if they were held while they were sick. And I think the retesting is probably up for debate a little bit with ID based on what we're learning about, how long it can sometimes persist even in the nasopharyngeal swabs. But again, you would never do this without a gastroenterologist on board. And one last note from a liver standpoint, to go back a second, obviously we always look for other reasons for liver injury. Remdesivir has about a 7% rate of sometimes abnormally changing the liver enzymes. Some of the other things like azithromycin or I'm blanking on it right now, but some of the other drugs are less than 3%, but something to consider as well. So sorry, I know that was a lot of information in a very short time frame, but I hope that's a helpful snapshot of what we've been seeing in the GI world.